Welcome to Eye Experts University. I'm Dr. Eli Sluge, and today we'll be talking about the eyeball anatomy. The eye is obviously the most magical organ in the body, so we're going to be learning about all the different components that make it so. So the eyeball is not a true sphere, but it's pretty close. It's an oblate sphere. It's about 24 millimeters in diameter and has a total volume of about 6 to 7 milliliters. The eye has three chambers, the anterior chamber between the cornea and the lens, the posterior chamber between the front of the lens and the back of the lens, and the vitreous cavity, which is everything behind the lens all the way up to the retina. Let's talk about the most magical part of the magical eyeball, the cornea. So the cornea is the windshield of the eye. It's avascular, there's no blood vessels, and it's very highly innervated. So when you get poked in the eye, it really hurts. It's about 12 millimeters wide and about 11 millimeters tall, but you can kind of think of it as a circle. The cornea is thinner in the center and gets more thick as you go more peripherally. So the central corneal thickness on average is about half a millimeter, about 120 microns. And as you go out to the limbus, it's usually a millimeter or a little bit more. Now, on average, because of the fluid-air interface, that's where the refractive power comes from, the cornea has an average strength of about 43, 44 diopters. The cornea is actually composed of 5 layers. It's got the epithelium, Bowman's layer, which is not a true basement membrane, the stroma, which is the meat of the cornea, comprising about 90% of the entire structure. Descemet's membrane, which is a true type 4 collagen basement membrane, and then the epithelial cells. The Bowman's layer is a tough layer, which is great for when you're doing superficial keratectomies. It really tries to keep the instrument from penetrating it. It's about 10 microns thick, and it does not restore itself after injury. So if you have PRK, your Bowman's layer is not going to come back. You'll kind of get this kind of keratocite, kind of scar tissue. Descemet membrane doesn't really have a lot of regenerative capacity, but you can put down some type 4 collagen versus Bowman's has absolutely no regenerative potential. The corneal stroma is composed of collagen lamellae with keratocytes in between with some pertinacious ground substance. Now, the anterior third has these oblique-oriented lamellae with interlacing fibers. This cornea has a much higher tensile strength than the posterior 2/3, which just have this parallel lamellae. Now, this is important for refractive surgery because if you're doing LASIK or PRK, you're actually removing the anterior cornea. So you're removing proportionally more strength from the cornea by removing the anterior layer. So when you do SMILE removes a deeper cornea, which has lower tensile strength, thus reducing the risk of ectasia. The Descemet membrane is a true basement membrane, so it does stain with a PAS stain because it's rich in type 4 collagen. The thickness does increase with age. So we start about 3 to 4 millimeters, and then as you get older, you get like 10. The peripheral corneal gotae are kind of known as the Hassel-Henle warts. These are more periphery, and they're pretty common. So sometimes you can see them when you look closely when you do a cataract pre-op. Versus if they're more central, that usually indicates Fuchs dystrophy, and that usually affects vision. The corneal endothelium is really cool. So these are the defoggers of the windshield. They pump the water out to keep the cornea nice and clear. So when we're born, we have about 4 to 5,000 cells per square millimeter. And as we get older, we start losing them. So probably in your 70s, you probably have closer to maybe 2,500. In Fuchs dystrophy, that condition accelerates, so you're actually having less and less endothelial cells. So usually when you're around 800 cells per square millimeter, you probably will need to have a transplant. Now, mitosis is pretty rare in endothelial cells in humans unless you're using the new Rho kinase inhibitors, which can kind of stimulate mitosis. So typically, those cells just kind of spread and migrate along the Descemet membrane to compensate for the cell loss, and there's only so far you can go. The sclera is pretty boring. It covers about 4/5 of the globe. It's opaque, white, and pretty avascular. It's thinnest at the rectus insertion muscles. So when you have a high force injury to the eye can actually rupture, and that rupture frequently happens right under the muscle. So when you do an open globe repair, it's important to take muscles down to try to find the area of the laceration if you don't actively see it. As in this picture, you can kind of see this kind of more grayish area in the superior left corner. So that happens in older people as the sclera begins to dehydrate more, it becomes more transparent. So that is an area of just kind of area of scleral dehydration. The limbus is the anatomic landmark between the cornea and the anterior sclera. This is also where the corneal epithelial stem cells live because they regenerate the epithelium every 7 days, and they actually reside in what's called the palisades of Vogt. You can kind of see these little striations if you look really closely. In some individuals, they're a little pigmented. The anterior chamber is the space between the cornea and the iris. It tends to be deeper in people who are aphakic, pseudophakic, or myopic, and it tends to be more shallow and more hyperopic people. The volume is usually about 200 microliters, and the deepest part is clearly in the center, and it's about 3 millimeters there. The reason why it's deeper in the aphakic and pseudophakics is because the way it is defined, the lens takes up a fair amount of space, so since the lens pushes the iris forward, it effectively reduces the size of the anterior chamber. When we look at the angle, which is not visible due to the bending of the light, we have to use gonioscopy to visualize it. We see that the angle is actually quite complex. That's where the eye drain is. So the first structure that we usually see is Schwalbe's line. That is the termination of the Descemet membrane. After that, we have our trabecular meshwork, and then we have the ciliary body insertion. The trabecular meshwork is a drain, kind of like our drain in the bathtub. And that's where the fluid that's made by the ciliary body as it flows out through the anterior chamber drains into the canal space. The trabecular meshwork is that spongy connective tissue that basically lines the entrance to Schlemm's canal, which is the circular drain that's about a millimeter behind the limbus that goes all the way around. Juxtacanalicular tissue, which is the tissue that's right up against Schlemm's canal, is the path of greatest resistance to fluid outflow. So that is the area of the trabecular meshwork that tries to be targeted with multiple glaucoma therapies to try to get it to open, like SLT or MIG surgery. So the Schlemm's canal is the circular tube that's similar to a lymphatic vessel that will then drain into the eye venous circulation through the collector channels. In most people, Schlemm's canal is a 360-degree continuous tubes with a single lumen, and it has about 25 to 30 collector channels. In some people, it turns out it's not a 360-degree tube. It can bifurcate in some areas, or it can terminate early. That's why when you do 360 cannulation of the canal during angle-based surgery, you sometimes cannot get all the way around. The uvea, which is a specialized vascular tissue, is composed of three parts, the iris, the ciliary body, and the choroid. And that's why when we have uveitis, we can get inflammation of different parts of the body, and you can see how anatomically it will be separated between anterior and posterior. The iris is the most anterior part of the uvea that we can all clearly see. It has a pigmented and non-pigment portion. The pigmented portion of the iris is more on the underside of the iris. Interestingly, the amount of pigment is what actually determines the iris color. It's not that iris color changes with the type of pigment. There is no blue pigment or green pigment or brown pigment in the eyes. It's actually all melanin, so it's all black pigment. And the density of the melanin is what determines the iris color. So the darker the eyes, the more melanin it has. The iris is actually pretty vascular. The blood vessels tend to be hidden by the pigment. In blue eyes, you can sometimes see them, but in darker eyes, you can't. So when you're using laser or you're doing eye surgery, you can easily inadvertently strike the blood vessel and cause a lot of bleeding and not notice it. The iris also has muscles. There's two muscles in the iris. That is the sphincter pupillae, which is in the pupillary border. It goes in a circle and it constricts to make the pupil smaller. The dilator muscle is kind of radially striated all the way around. The iris posterior pigment epithelium is continuous with the non-pigment epithelium of the ciliary body, which is part of the neurosensory retina. This is a hugely testable question for some unknown reason. Ectropion UVA is a condition where contraction of the anterior side of the iris causes it to kind of evert on itself, thus exposing the pigmented portion of it. It is one of the signs in iris neovascularization. The iris dilator muscle is derived from neuroectoderm. It is smooth and it is innervated by the sympathetic fibers. The interruption in the sympathetic chain will cause meiosis, ptosis, and anhidrosis, because that is what the sympathetic chain does during its pathway. The iris sphincter muscle is also of neuroectoderm origin. It is innervated through the parasympathetic system of the cranial nerve 3. Pupillar motor fibers run on the outside of cranial nerve 3. So compressive lesions like aneurysms affect the pupil or they will affect the motor system. This is in contrast to an ischemic like a diabetic third nerve palsy because the inside of the nerve gets affected the most and those are the motor fibers. So that tends to be pupil sparing. So the ciliary body is what makes the aqueous fluid. That's its main function. It also assists through accommodation through its muscle contraction. So the pars plana part of the ciliary body is pretty smooth, avascular, and sits about 3 to 4 millimeters from the corneal limbus. That typically is the part where we prefer to inject our intravitreal injections. Now, the pars plicata is virtually vascularized. It's got 70 radial ciliary processes, and that is what actually is biologically active and makes the aqueous humor. The ciliary epithelium is a double layer where the inner is non-pigmented and the outer is pigmented. This is the opposite of the iris pigment epithelium. The non-pigment epithelium has the tight junctions and forms the blood aqueous barrier. The sodium ATPase is what drives the aqueous secretion of the non-pigmented cells. Carbonic anhydrase is involved in aqueous fluid production by the non-pigment epithelial cells. So carbonic anhydrase inhibitors affect that area to reduce aqueous production. The muscle of the ciliary body is what allows for accommodation. It has 3 fibrillaries, the outermost longitudinal muscles that actually insert the scleral spur. They're the most abundant, and this is what actually attaches the ciliary body to something hard that's in place. The mid portion is the radial fibers, and then centrally is the circular fibers, which allow for accommodation. As they constrict, they reduce the tension on the lens, which causes it to relax and become more spherical, thus gaining refractive power. When that happens, we are able to see things better that are closer to us. It is innervated by the parasympathetic fibers, and because it's parasympathetic, it is affected by cholinergic and anticholinergic drugs. Presbyopia, which is a condition in adulthood where we lose our accommodative power, is not due to the weakness of the muscle. It is because the lens loses elasticity. Thus, even when the muscle contracts to try to allow the lens to relax, the lens just can't because it's too rigid. The choroid is the clearly much a bigger part of the uvea. It's about 250 microns thick, and its job is to nourish the outer retina, which is the photoreceptors and the RPE, which is the most metabolically demanding area. It's got three layers. It's got the choroid capillaries, which are large fenestrated capillaries, the middle layer with some small vessels, and the outer layer with some larger blood vessels. The blood supply is from the long and short posterior ciliary arteries and a few anterior ciliary arteries. The venous drainage is through the vortex veins. Those are the big ampoules that you find kind of in the mid-equatorial region. The lens is ideally clear and avascular. It contributes about a third of the refractive power of the entire optical system. It measures about 6.5 millimeters in diameter at birth and kind of grows to around 9 to 10 millimeters. Same thing with thickness that starts around 3. It can grow to 5 or 6 millimeters in width in adults when it's time for cataract surgery. There is no innervation, and it's totally metabolically dependent on the aqueous for all of its needs. It's enclosed in a capsule, and it has stem cells at the anterior preequatorial germinating layer. So as you age, your lens ages with you. The crystallins are the oldest proteins in the body because they're not removed. They form with fetal life and continue to grow with you. That's why when you do cataract surgery, it has different layers of which layer became opaque, and that's why you can get fetal cataracts and embryonal cataracts. The anterior capsule is the place that has epithelial cells. Centrally, they don't do much, and as you move towards the periphery, towards the germinating zone, that's where the stem cells are and the mitosis happens. The lens is composed of crystallins, and alpha crystalline is the most common one in the lens. The lens capsule has a basal lamina made by the lens epithelial cells, and it is also made of type 4 collagen, like a basement membrane. The anterior capsule is much thicker, about 15 microns. The posterior capsule is much thinner, about 3 microns. Hence, why it's so easy to break the posterior capsule during cataract surgery. The zonual fibers originate at the basal lamina of the non-pigment epithelium in the pars plana and pars plicata of the ciliary body. And as you can see, they kind of attach diffusely at the equator, both anteriorly and posteriorly. The way accommodation works is when the muscle is constricted, the lens relaxes, and we see up close. When the muscle relaxes, this actually tenses the zonular fibers and puts them on stretch, which then makes the lens thinner and gives us a distance vision. This is the position where the lens freezes as we get older. There are conditions where zonular fibers are weaker because they're made of collagen, like Marfan syndrome. That's one of the conditions where you can get a floating lens or ectopia lentis. The retina is thin and transparent. The inner layer is the one that's most close to the center of the eye, and the outer layer is the one that's most close to the sclera. It has a bunch of components. If you look at the chart on your right, you will see the top starts at the outer layer and then works its way in. So we got the retinal pigment epithelium, we got our photoreceptors, we got a bunch of neurons, finally going down to the ganglion cells and the ganglion cell axon. The retina is thickest just around the fovea, and the fovea itself is actually the thinnest area. The reason why OCT of the retina works so well is because the retina is transparent, thus light can go through it, and with the principles of interferometry, we're able to discern the density of the transparent layer. The macula is the area within the two central arcades. It's about 5 to 6 millimeters in diameter. The fovea is the very central vision. That's where the majority of the cone cells are, and that is a super high metabolically active area. The fovea centralis, or the major fovea, is about 1.5 millimeters. The foveola itself is like 0.35, and it only has cones. There are no ganglion cells, it's just cones. That's where your super sharp central vision is. The optic disc, as you can tell in the picture, does not have any photoreceptors, thus that's what causes the blind spot. Brooks membrane is a true membrane that forms of the basal lamina of the retinal pigment epithelium. This extends all the way from the optic disc margin to the ora serrata. There are multiple layers to Brooks membrane. They're not particularly important, but they're basically different types of collagenous material. Brooks membrane is what separates the blood from the retinal structures in the RPE. So when you have breaks in Brooks membrane, a new blood vessel can leak through and cause a neovascular hemorrhage, such as trauma when you have Brooks membrane rupture or other eye conditions. The retinal pigment epithelium is what services the photoreceptors. It takes care of the byproducts of vitamin A metabolism and eats the outer segments of the photoreceptor. It helps with light absorption, heat exchange, and again supports the basement membrane, which is the Brooks membrane. The tight junctions of the retinal pigment epithelium is what helps create this blood-brain barrier. The photoreceptors would actually register as light. There's 120 million rods and 6 million cones, all concentrated around the fovea. So the rods have stacked disc in their outer segments and they're renewed by shedding. The cilium has a 9 plus a 0 configuration and does not move. The cones have the discs attached to the cell membrane in the outer segments, and they're renewed by membrane replacement through the help of the RPE cells. So the main thing to remember here is that the rod discs are free and not attached to the cell membrane versus the cone discs are attached and are shed with the membrane. The retinal neurons are the cells that actually convert the photoreceptor signals to nerve cells so we can actually register that light with our brain. There is a large number of neurons that all support this function. The main thing is that the Mueller cells span the entire retinal thickness, and their apical processes start at the external limiting membrane and the foot plates and at the internal limiting membrane. Most other cells are only just part of the retina. The retina has two types of blood supply. So the inner retina is supplied by the branches of the central retinal artery, while the outer retina, which is the photoreceptors in the RPE, are supplied by the choroid capillaris through the short and long ciliary arteries. Now, the ciliary-retinal artery is present about 30% of people, and it's an artery that's different from the central retinal artery. So some people can stroke that one out, and they just have a central visual field deficit, while other people, when they have a retinal artery occlusion, they can stroke out the rest of the eye, but the ciliary retinal artery will continue to perfuse the center, and those people can retain some central vision. The ora serrata is the boundary between the retina and the pars plana. It's about 6 millimeters from Schwalbe's line. It's larger in myopes because the myope eye is longer, and it's small in hyperopes because the hyperopic eye is shorter. The nasal part is serrated versus the temporal part is relatively smooth. Diameter is about 20 millimeters, nothing too exciting. The peripheral retina is markedly attenuated over there, and you can usually see a distinct border, as you can see in the cartoon representation of where the serrated portions meet the kind of retina part. So when you actually are doing ophthalmoscopy, you can see the ora serrata border. The significance is that this is where the vitreous base is attached, and this is the most common area for horseshoe tears because that's where the vitreous has its area of traction. The vitreous is a gel that occupies about 4/5 of the whole globe volume, about 4 milliliters. It's 99% water, and the rest is basically hyaluronic acid. It attaches at the ora serrata, which is the strongest attachment, It also attaches at the disc margin and detaches over there to cause a PVD or posterior vitreous detachment, which then causes a bunch of floaters. And the Weiss ring that you see as part of it is the old detachment place. It also attaches along the retinal blood vessels. That's why it can cause a hemorrhagic vitreous detachment if it tears one of them. And it has some attachment to the posterior lens capsule, but it's usually not that big. Cloquet canal is the central kind of S-shaped opening through the vitreous. It's an embryological remnant. The vitreous gel liquefies of age. Just like if you leave jello on the table for a while, it's going to start melting. Same thing with the vitreous. So the vitreous attachment initially separates the posterior pole and then migrates anteriorly. The process is accelerated in nearsighted people because their eye is longer, thus the stress on the vitreous gel is higher. When that happens, you get symptoms of floaters. That's the new pieces of the vitreous start floating around. You can get floaters from torn blood vessels, and you can actually see individual red blood cells floating. Those are the shower of gnats. You can get flashes of light. That's the area of traction when the retina gets pulled on. The mechanical force triggers the photoreceptors and neurons to send the flashes to the brain. And finally, if you get a retinal detachment, you'll see a shadow because the photoreceptors have detached the RPE and are no longer working. We think the vitreous is an oxygen scavenger because people who had a vitrectomy done and had the vitreous removed develop a cataract within a year or two because it really increases the oxidative stress on the lens proteins. Therefore, while vitreous gel is annoying, it does serve a function. However, it turns out if you have cataract surgery and you had the vitrectomy done, nothing else happens. The optic nerve is about 1.5 millimeters in diameter. It usually has a cup in the center because all the nerve tissue basically exits radially and the center just is unoccupied space. It has about 1.4 million optic nerve fibers, which average about 40 millimeters in length. The nerve fiber layer has different layers. It's got the superficial nerve fiber layer. It's got the prelaminar layer with some astrocytes. It's got the laminar area where it actually goes through the lamina cribrosa. And it's got the retrolaminar portion. That's where the eyeball exits and actually goes back towards the head, as we'll see in the next slide. Nerve is about 1 millimeter long in the intraocular space. Then it traverses about 25 to 30 millimeters from the eye towards the optic canal. Through the canal, it has about 4 to 10 millimeters to travel until it exits inside the brain. And then it travels about 10 millimeters where it links to the optic chiasm.